Hey everybody, how's it going there? This is Timothy Gentry, a staff paramedic at Cooper University Hospital EMS. I just wanted to go ahead and tackle a pharmacology review. This is for, it could be new hires at the EMS system itself, or it could be for the special operation combat medics that are coming through doing their training. One of the reasons I wanted to do this was obviously to, for your benefit so you can better learn the drugs that we carry, but this is also my way of getting around the fact that I only get to see everybody at certain times, right? So you're limited to whatever my schedule is, and that's not fair because I only work 36 hours a week here. So this is my way of remotely providing the content, and I'll upload it to whatever medium I need to, and we can disperse it as such. So let's go ahead and get started. Objectives here, obviously we want to learn the names of the drugs, both generic and brand. I'm not going to go over that too heavily because you can just read it within the slide itself. I'll provide the PowerPoint after the fact along with this video recording. But keep in mind, we want to go over the concentrations, the doses. We want to know the protocols where we're using these drugs or the clinical situations. And we also want to understand the pharmacokinetics and the pharmacodynamics at a basic and hopefully eventually a more advanced level. I don't want to beat a dead horse because I know everybody kind of comes from different backgrounds, especially the CUHEMS students. They come from a very eclectic background, so they might have different experience as far as education goes, as far as experience in medicine goes, and I can appreciate that. But I want to add a baseline, just reiterate or refresh pharmacology, anatomy, and some basic biochemical concepts that you've probably previously learned, especially the CUHEMS guys. It's kind of like when you're going through and you're getting your clinical training, it's like drinking through a fire hose, right? You're getting a lot of information overload, so this will serve as a good refresher so that you don't fall behind. Assumptions here, just keep in mind, that all of the drugs that we carry vary widely amongst EMS systems, whether it be in New Jersey, the whole state, this system itself, Cooper versus another one in some other part of Jersey, or, just as a nation entirely, everybody kind of works differently. So it's really important that you just know your state and national protocols and standards, right? So the SOCM guys, you're testing to national registry standards, so make sure that you know your registry standard. The drugs that I'm going to go over are just the ones that we carry, right? And the pharmacokinetic and dynamic information that I'm providing it typically only pertains, I know it widely varies, but it only pertains in this slideshow to the intravenous route of administration. A lot of these drugs, right, you can give them intramuscular, intranasal, transdermal, et cetera, et cetera. So that's obviously going to deviate the onset, the peak, the duration times, and whatnot. So just kind of take those with a grain of salt. I'm not going to actually read them out loud as we go along here. And again, these are just broad applications of the drugs, right? So I'm going to go over some of these drugs, and you're going to say, well, wait a second, you're using that for X, Y, and Z, but we use it for, LMNOP. And I get that, right? So whether it be the hospital or the battlefield, these drugs that I'm going over obviously have wide applicability, right? So you're going to be able to use them in a lot of different clinical situations, but the ones that I'm reviewing typically just pertain to EMS because hopefully when you're coming to do your EMS ride time or you're orienting, this is your review so you know what we carry and you know what to expect. A little bit about me. I got interested at a young age in EMS. I think it was because my mother and father were 6-8 whiskeys in the Army. I've been working EMS for about 10 years now. More than 2 of those years have been spent in Camden City here, state of New Jersey. I'm from Philadelphia, right across the river. As far as my training goes, I did my National Registry Paramedic at Thomas Jefferson University, which is located in Center City, Philadelphia, if you're not familiar. My Bachelor's of Science was obtained from Philadelphia University, which is actually now owned by Thomas Jefferson University. And lastly, what I'm doing right now is a Special Master's program at the University of Pennsylvania, located in University City, Philadelphia. And the hopes are that I complete these more advanced biochemistry courses, and I'm going to go ahead and take the MCAT in a little bit here and apply to medical school. So fingers crossed. Moving on. Drugs carried. This really doesn't provide any qualitative data. It just shows you an alphabetical list of the drugs themselves. Should you want to review it in alphabetical order when I disperse the PowerPoint, feel free to do so. But I think this is a little more useful. This is the drugs that we carry by category, right? So we got our narcotics and our RSI meds. That's what we're going to tackle in this video. This is the first video. We're going to hit those drugs right there real quick. After that, we have our cardiac and antiarrhythmic medications, and then all the other ones lumped into, an others category. All right, so yeah, here's our abbreviated review of narcotics and RSI meds. First up is fentanyl. So whether you be civilian, EMS, military, everybody at one point or another, especially with the current epidemic, has heard of fentanyl or opioids and opiates. Fentanyl we use quite often. We're using it a lot for analgesia or sedation after extremity trauma or just trauma in general, like burns. We use it for angina, for chest pain, and we also use it for RSI. So opioid versus opiate, right? Opiate is natural, whereas opioid is synthetic. It's an opioid for analgesia, pain relief, and it works by agonism of the opioid receptors, right? So one thing to take away, because a lot of people don't know the difference between fentanyl and morphine, is that it binds about 50 to 100 times more strongly than morphine. So this is because of that increased lipophilicity, right? That means it'll more easily penetrate the central nervous system. So RSI might be a little bit confusing or funky if you're not familiar with the medication, but after we intubate somebody, RSI is rapid sequence induction. After we intubate somebody, you might see some sort of markers when you're trending their vital signs that they're experiencing some sort of pain, right? Because whether it's their primary ailment or their a severe trauma or whatever reason you RSI'd them, right, the procedure itself can even be painful. You'll see maybe a spike in blood pressure, a spike in heart rate, and that'll lead you to believe that maybe they're experiencing pain. So unconscious or not, paralyzed or not, you want to keep your patient pain-free. Just be wary of the side or adverse effects, big ones being that decreased respiratory drive, which leads to subsequent hypoxia. Nausea, vomiting on the later side if they are conscious when you're administering it to them. But yeah, you want to be careful of that CNS depression, right? Because we don't want them to become hypoxic, especially if we're RSIing them. Moving on, midazolam. It's also known as Versed. You'll hear it referred to as Versed. You can think of the azolams as typically benzodiazepines more often than not. Some other companies carry lorazepam or diazepam, which is Ativan and Valium respectively. But at this system, all we have is midazolam or Versed. So we're using it for more often than not severe agitation in lieu of ketamine or acute management of seizures. That's when you'll see it more often than not used in this system, is the acute management of seizures. But if you are using it for that procedural sedation, whether it be resetting somebody's shoulder in the hospital environment or whatever, you can use it or you can pair it with an analgesic like fentanyl. Or if you are using it for that severe agitation, the patient that's a threat to themselves or EMS in general, you can pair it with haloperidol, Haldol, which we'll review at a later slide. How it works, just real briefly, it enhances the effect of the neurotransmitter GABA on the GABA A receptors, which means it's increasing frequency of that chloride channel opening up, which results in neural inhibition. Again, be careful of that decreased respiratory drive and that subsequent hypoxia. That's critical. And you also want to watch out for hypotension with midazolam because you have decreased systematic vascular resistance. So you really want to be judicious if you're administering this, and you need to have fluids hanging or whatever it be. You need to make sure you're paying attention to your patient, which is a given, right? Etomidate. So we're moving on to some of the RSI medications. I understand not everybody uses RSI, but it's still a good refresher. Etomidate is our general anesthetic or sedative. It's short acting, and we use it for induction of general anesthesia. Typically, the only time that we have used it in this system pre-hospital is for tracheal intubation, right? So RSI, rapid sequence induction. So this is what we give prior to the paralytic itself when we are going to move forward in RSI. Side or adverse effects, be careful that myoclonus, right? Myoclonus and laryngospasm, people get very, very afraid when that occurs. I have not seen it myself, but you also need to be aware it is a possibility. So have your, emergency or backup airway kit available if you need to do an emergency airway. Also, it decreases adrenal function, so keep that in mind. Ketamine, this is a big one. A lot of people are real hip on ketamine, and a lot of people are using it for a lot of different things, right? So it is And again, you can see in the slide in bold, it has many, many uses, right? So you can use it for anesthesia, bronchodilation. We're seeing it used in some of our respiratory patients, analgesia. It's even being used as an antidepressant. But what this is a dissociative hallucinogen, right? So it's an NMDA receptor antagonist and general anesthetic. I'm a little bit rusty on this, so don't quote me, but I'm pretty sure the NMDA is the N-methyl D-aspartate receptor. And essentially it's a glutamate receptor and ion channel protein that's found in nerve cells, right? So that NMDA receptor is one of 3 types of those ionotropic glutamate receptors. I'd have to think of the other one. I think the other ones are like the AMPA and the kainate, whatever receptors. But just know that it's an NMDA receptor antagonist, and that's how it works as a general anesthetic. When you'll see it used with us, a lot, is for severe agitation, or some people call it excited delirium, and for RSI, right? So this is our go-to for our rapid sequence induction when we need to get that general anesthetic and that sedative on board prior to the paralytic. You'll see the ketamine used pretty often. Side adverse effects, just again, like most of the other ones, be wary of them. And the big one that people talk about is the increased laryngeal or tracheal secretion. So just have your suction ready and on standby. I'm going to see if these videos do work. So this one, it's your boy ketamine. Watch that in your spare time if you want to. It's not that. It's just a fun little rhyme on. It's a rhyme on ketamine itself. But let's see if we can get this video to open, and if I can get it within where we're recording this screen, right? So this is you can kind of see here. And sorry for the. Let me see. Hold on. Sorry that I have it only confined to this little screen, but you can get an idea, right? There's a guy walking around naked and bloody. You see this quite often. And he's just totally out of it. Punching fences, losing his mind, right? He has no idea where he is, what he's doing. Typically, force like this is ineffective, and they'll just continue to push forward with whatever they're doing. But yeah, ketamine is great, right? So we want to keep them from being a threat to themselves and to the crews, whether it be law enforcement or EMS. We want to just ensure safety. So typically we'll use ketamine for somebody like that, excited delirium. And you'll see that a lot. You'll see that from when, somebody's using some sort of illicit substance or whatever it is. So just, keep that in mind. It's very, very useful, and it works very well intramuscularly, because patients like that, you're not going to have the time, or you're not going to want to take the time to start an IV on them to get them under control. Moving on, we have rocuronium. Rocuronium, this right here is our non-depolarizing neuromuscular blocker, right? So neuromuscular blocker, we think paralytics, because this and it's an analog of vecuronium, but this and vecuronium are go-tos for induction of skeletal muscle relaxation, or more paralysis is what you hear more often than not. It's our paralytic. We use this for RSI, rapid sequence induction. And why we use it is it antagonizes that motor end plate acetylcholine receptor. Well, receptors. It antagonizes all the acetylcholine receptors at the motor end plate region. And we can review that. I put in a slide about the neuromuscular junction just as a quick review, so you can kind of visualize that motor end plate region, because it is important to understand why it's doing what it's doing, and where it's happening. Side and adverse effects, right? So just be careful that transient hyper or hypotension. Residual paralysis, right? So if they're paralyzed for a little longer than expected, be prepared to manage your airway, and then increased pulmonary vascular resistance. Moving on to another paralytic, typically only used in times of shortage. We don't carry it anymore on the truck, but it is good to know, is rather than our non-depolarizing, right, which was rocuronium, we now have our depolarizing neuromuscular blocker. And it's good to know the difference between depolarizing versus non-depolarizing. So you'll hear this called SUX a lot, but it's succinylcholine or anectine. And again, it's used for the induction of skeletal muscle paralysis. And how it works is it blocks the action of those acetylcholine on skeletal muscles. Side and adverse effects worth mentioning is that malignant hyperthermia. I know a lot of people are afraid of it with the SUX, but typically you're only prepping for that in maybe an OR. We don't see that in the pre-hospital environment, but it is good to keep it in mind and also be aware of hyperkalemia and acute rhabdo, right? Because those could be some serious problems in the pre-hospital environment, especially if you're utilizing this for, let's say you have a severe burn patient that you need the RSI. This might not be the best choice of paralytic, but anyway, so how it works, it's, well, actually I should say as a review, just to kind of think about how it blocks the action of that acetylcholine. You think to yourself, okay, well, what is acetylcholine and what does it have to do with skeletal muscle? I don't know how much you know about acetylcholine. There's a lot to be said about it, right? So it's a chemical messenger, it's a neurotransmitter, and it's released. It's released by nerve cells in many parts of the peripheral nervous system. Essentially, the important thing to take away from that is it controls the contraction of all skeletal or voluntary muscles. That's huge, right? That's a big deal. That's important for you to know. So now think about this, right? So this is a depolarizing neuromuscular blocker. Depolarizing muscle relaxants act as acetylcholine receptor agonists. They essentially bind to those acetylcholine receptors and generate an action potential. And action potentials you can think of, if you're looking at oscilloscope readings or you're looking at actually if you're looking at an EKG in general, right, you can think of your, let's see, you can think of your action potential, right? So let's say we have your standard EKG, right? So let's say something like that. So when we think of action potential, we think about that depolarization, right? That rapid depolarization. So going back, think about that again, right? So when they bind to those acetylcholine receptors and generate an action potential, they're generating that depolarization. So you're thinking about the motor neurons and the electricity changes going on. So it's important to keep all of that in mind when you're thinking about depolarizing muscle relaxants, right? So non-depolarizing is different. They basically act as a competitive antagonist rather than an acetylcholine receptor agonist. They act as a competitive antagonist. So they bind to those acetylcholine receptors, but are unable to induce ion channel openings. They basically prevent the acetylcholine from binding, and thus end plate potentials do not develop. So they work very, very different, but they're useful in the same manner in that they're great paralytics. They're good for RSI. I don't think the action potential, the whole bit on action potentials really hits until we'll get into the cardiac medications, and I'll maybe be able to better explain resting membrane potentials and whatnot. But anyway, the big thing to take away from that is it's depolarizing. SUX is depolarizing. Rocuronium and vecuronium are non-depolarizing neuromuscular blockers. So here we go. We'll wrap up this little lecture with the neuromuscular junction, right? So this is really neat to see. You have all of the important anatomy here to envision, right? So you have your insulation, your myelin sheath for the axon terminal, this is your neuron, right? So this is coming off of those somas, and the action potential propagation happens in here, and then it comes down. And so here you go, right? Here's your vesicles of acetylcholine. They make their way across this little open valley here to the motor end plate region, right? So there's your important one. There's the one that we were talking about earlier. And here, right here, are all your acetylcholine gated receptor channels. Why is this important? Well, because that action potential propagation in muscle fibers and all of the normal functions going on here with the voltage gated calcium channels and the acetylcholine channels, all of this leads to contractile or normal contractile elements within muscle fiber, or just it basically leads to normal function. So what will happen, to sum it up as quick as I can without diving too deep, because I don't want to put my foot in my mouth, is so that whole neuromuscular activation, right? You're going to have that influx of calcium in nerve terminals, and it's going to lead to that release of acetylcholine. When that acetylcholine binds to the nicotinic receptors at your motor end plate, it's going to cause that depolarization, right? The sodium entry. And that, again, dials back to resting membrane potentials, right? Because your sodium and your potassium and all of your other cations and anions have varying resting membrane potentials that cause depolarization, repolarization, etc., depending on which one is in excess. And then lastly, you're going to have that action potential, right? It's going to be caused by that sodium influx, and it's going to depolarize the muscle fibers. But anyway, this is a good slide to review the neuromuscular junction. I think it's a really quick and easy picture to understand. And you know what? It even has labeled 1, 2, 3, 4, 5, 6, 7, 8. It gives you the steps right here if you want to dive farther into it. But I thought it was worth a slide just to review when we're going over RSI and whatnot and pushing paralytics. I think it's pretty important to understand. But again, next we'll move on to the cardiac and antiarrhythmics.